Welcome to Flames of Knowledge, a CFSI podcast where we analyze federal policies, spotlight leadership, and tackle issues that matter to the fire and emergency services. Stay informed, stay engaged, and let's get to work.
Welcome to CFSI's podcast. I'm Michaela Campbell, Executive Director of CFSI, and today we are focusing on the critical issue of smoke inhalation and smoke-related injuries. In this episode, we'll talk about the current data, how our understanding of smoke and smoke-related injuries and deaths has evolved, and how we can take steps to address it. I'm excited to have the chance to have this conversation with three experts in the field. Tommy Begres serves as a full-time firefighter paramedic in Southeastern Michigan and as a clinical consultant for SERB Pharmaceuticals. Dr. Robert Dunne is the medical director for the city of Detroit and the program director for EMS Programs at Wayne State University. And Ryan Elborne serves as deputy chief of EMS Operations for the DC Fire and EMS department. Let's talk about the history for a second. So how has our understanding of smoke and smoke-related injuries and deaths evolved, and kind of where are we today based on that data? And I guess Chief and Dr. Dunne, I don't know if you want to jump in here, but it seems like we're in a different spot than maybe we have been previously.
Sure, I'd be happy to, and thanks for having me. Essentially, you have less time. The materials that were used to homes being built in the first couple centuries that the country was building homes, wood, cotton, materials that burn, we'll say cleaner. And over the last several years, we've noticed and seen that building construction has changed considerably. And what we're starting to see is, and have been seeing, is a lot of polyurethane, nitrile products. All of these contain nitrogen. And when nitrogen burns, it produces hydrogen cyanide. And so beyond that, we're also seeing there's more stuff in your house, right? There's more stuff in your living room. Your TVs are made differently, couches are made differently, chairs are made differently. So even though we have detection systems and even though we have smoke detectors and we have rescue plans and exit strategies from our homes, we're up against a time factor we weren't up against 50 years ago.
Thank you, Chief. Dr. Dunne, what are your thoughts?
The other thing I'd say in there, so it's, when I talk to people about this, I often encourage them to look around the room that they're in and try and find something that's actually a natural piece of wood or something else, because we are looking at complex chemistry building most of the things that we use in our homes, in our offices, everywhere, right? We see this even in car fires and things like that. But back to the timing, some of this is we know a lot more about what it takes, right? Some people who clearly died before were a statistic in the 70s, in the early days of advanced life support. We know now that on-scene care, that quick response, getting really good quality care that is informed by the evidence makes a difference in saving lives. So I'd echo Chief's comments about, it's really that time and recognition. We really need to be right on top of these.
What does the latest data show about the risk of fire-related mortality in the U.S.? And Tommy, maybe you could take that one from the top.
Michaela, thank you for having me today. It's a great opportunity. The data is interesting. The current U.S. Fire Administration data shows that the per capita fire-related mortality risk has actually increased 27% between 2014 and 2023. And the fire incidents contribute to more than roughly 38,000 deaths annually in the United States.
That's fascinating. So according to the most recent data, what types of fires are most likely to result in fire-related injuries or deaths?
So the data is really very clear-cut that the majority of incidents where there is a fire-related injury or death is most commonly occurs in a residential structure fire. So a structure where someone resides, whether it's multifamily or single-family dwelling. Those are the most common fires that will result in that. Now, on top of that, the causation portion of it is smoke inhalation is the leading contributing fire-related factor, whether it be injuries, which accounts for smoke inhalation accounts for 56% of all fire-related injuries, or with fatalities, Smoke inhalation is a causative factor in 85% of those deaths.
Yeah, I know UL's Fire Safety Research Institute has been doing a lot of work on this. Chief, just a follow-up question for you, just as a PSA. So for the fire service listeners, they'll know this, but for some of our general public listeners, how long do you have in the event of a fire to try to get out, or where you're really starting to see the burn pick up?
I don't have a scientific number or any study data with me for that one. I do know that we in DC tend to pride ourselves on water on the fire and how fast we're able to accomplish that with 33 firehouses over 67 square miles. But I do know that there are still times that even with a 3 and 4 minute response time, we're still responding to fatal fires.
Wow. So with the pace of everything kind of increasing, I know, Dr. Dunne, you mentioned the treatment opportunity window. So I guess we should segue into what treatments are available and used to treat, and then also what is that window and what does that look like?
So the first thing is good care, right? Having a team there with advanced life support and enough people to care for the casualties that come out of the fire. So you need to get there, you need to start fire suppression and rescue activities, right? You need to get some intelligence about the fire, what's going on, how many occupants there may be, find the occupants and get them out. As you're getting them out, you're doing that initial assessment. How do they look? Are they breathing? Are they talking? Are they already unconscious, right? And you're handing them off to your teams that are caring for them. And there's a number of challenges. Someone who has inhaled a lot of hot gas could already be on their way to having an airway obstruction. So we need to manage that airway. We need to be able to have the tools to manage the airway quickly and efficiently. You may only have minutes. Sometimes that can be a delay, something that's delayed 30, 40 minutes. Some people get to the hospital and hours later have airway obstruction from hot gases and irritants. So that initial assessment and being able to provide advanced life support, being able to get vascular access, an IV or an intraosseous line, being able to give appropriate medications for what you're running into. But again, doing that assessment and being able to start treating right there on scene is essential.
So what do departments need to do to make sure that they can treat on scene?
So I think everything that Dr. Dunne said regarding having the appropriate team in the appropriate place and also the appropriate equipment for that team. And in our experience in DC, the appropriate equipment has been an antidote for cyanide poisoning, and we've used the cyanokit for a number of years.
In addition, all the other things, right? Many patients who are disproportionately affected by a fire in their home are people that already have medical conditions. They may have some lung disease, they may have heart disease, they may be older folks. They have a hard time self-rescuing, so they get exposed to the fire a little bit longer. So being able to have kind of all the tools that we would normally be taking care of patients in our community with is also important. And I want to just mention, and I think the chief could mention too, the importance of training with scenarios that are fire-based, right? Think about learning from our own experiences, learning from the experiences of other departments. So we're providing that level of care quickly and efficiently, and it's not the first time we've done it. We've trained on it. We're ready to do it.
Could you expand on that a little bit? What does training look like to you? What do you think is the key to a successful training program?
If I'm kicking that to you because I love what you guys are doing.
So training for us is realism, right? As realistic a scenario as we can get. So that's everything from live fire training to all of our special operations training. But when it comes to training for serious medical patients, we actually have a full-on simulation lab at our training academy. It's fully immersive. We can put you outside of a house fire, and we can put you in a metro station, and we can put you everywhere in between. And I think that, availability, time, and cost seem to be always the three things that get in the way of good training. And we have we've overcome those as best we could to try to provide a realistic experience for our recruits and our cadets and our new paramedics, as well as our veteran firefighters all the way through.
So that leads me into another question I have, which is, Chief, can you kind of keep going? How has treatment of smoke inhalation victims evolved within DCFD?
So that story goes back to 2019. And it literally goes back to seeing some cyano kits on a shelf at our logistics warehouse and asking a couple of questions. In 2019, we were carrying cyano kits on our EMS supervisors, and we deploy 7 EMS supervisors a day, 1 in each battalion of the city. And they were the only people that had them. Also, they were not initially dispatched on a house fire. So there were a few systemic changes along the way. The first thing was asking, well, why are these going to sit on the shelf and expire? And nobody really had a good answer. So we had an assistant medical director at the time, and I asked that doctor, hey, would these be better if we put them in medic units? And he said, I don't know why they're on a shelf. And I said, well, let's fix it. So in 2020, it took us going a little bit further to 2020 that we finally got them there. And we used to have 8 in the field every day, and we tripled that in one day to 25. So we had 25 cyano kits available, 1 on every medic transport unit and every supervisor. And then we increased the numbers on like our EMS battalion chief and our special operations supervisor. Within a couple of months, we also added medic units to our initial box alarm dispatch, which we didn't have for the first 15 years that I was here. So now 2 transport units are on every box alarm dispatch in addition to all of the fire apparatus. And in 2022, I was able to sneak the supervisors in there too. So now 2 ALS resources and a BLS resource go into every reported structure fire in the district. So what did that do? It didn't park us 2 blocks away with the equipment that we should have with us. It didn't put us 10 minutes behind the 8 ball waiting for a work and fire dispatch. What it did was it put the resources in the front yard where we need them when people are getting pulled out of a building, right? It also put the resources there for our people in the event something catastrophic happens. So what did that look like for us? We were averaging about 450 days in between cyano kit administrations in 2019. And when we put them on the street, and we started to socialize that they're here and we need to use them, and there are more of them available now. We cut that down to about every 2 months. And then the last move was the supervisors. When we put the supervisors on box alarms, having that supervision there, we're down to about 30 to 40 days in between uses now.
So 2 follow-up questions on that. The first one, we'll start there, is given the way that you guys have sort of rolled out and improved how DC Fire responds and has the treatments available, what are some best practices that you think would be relevant to other department types or that they might be able to pick up and utilize? What have you guys learned that you think is pretty easily implementable for a wide variety of folks?
I think it's a matter of knowing where they're going to do the most good. So I understand there's a cost associated with any treatment and any medicine. And so I think that knowing where the most good can be done is number one, and not necessarily putting them. I think in a way, I'll go backwards and say, we almost had them in a place where we knew they weren't going to get used. And I think doing a 180 on that and saying, where can they be placed that they're going to do the best for everybody was probably the first thing. And then the second one is training. And if we don't train people to use these, not just when they're in the academy, but kind of refresh them pretty regularly, then they end up being that thing in this Pelican case that we forget about, right? So we have done at least annual training at our paramedic grand rounds. One of the stations for paramedic grand rounds, one of the skill stations is the assembly and administration, of a cyano kit, along with all of the other ALS skills that might be in there.
Michaela, can I add to that? I think it's important to note to let the audience understand that DC has done an amazing job. I think the other thing that I see as I cross the country and talk to other firefighters is also an acceptance or a thought that, well, they can wait till they get to the hospital. And that's really something that we need to start getting away from, especially with that the smoke is different now. It's more caustic. We know now that that the treatment window has narrowed, and that we can't necessarily take the mentality of, well, we can wait till they get to the hospital is the correct way. I think that's another thing too, that we have to really get the fire service away from thinking.
And if I could just support that, right? So this is something that we've learned about everything we take care of, right? We know that even if I'm across the street from the hospital, and for instance, you have a cardiac arrest, your chance of survival, if I just pick you up and bring you to the hospital, is effectively zero. We know that things like defibrillation, airway management, early use of medications need to be done as soon as possible. And we've gotten this message out there, but it's not always learned. And what we see when we're responding to a fire is a little bit of the microcosm that we've seen in other parts of our pre-hospital, out-of-hospital care. We need to understand what things are high yield and how we're going to save a life. So when we're talking about cyanide exposure in a fire, cyanide kills you very quickly, right? Like many other toxins that have antidotes. Lots of things that are out there that kill you, unfortunately, I don't have an antidote for. I can provide supportive care. But for things that have antidotes, whether it's, cyanide or, insecticide exposures, I need to provide those as soon as possible. The sooner I get you the appropriate antidote, the faster you're going to recover and the less chance of you having some long-term disabling condition from being exposed to that, right? So we really want to be focused on treating right there as soon as that patient comes out. So what Chief's talking about getting your ALS resources to the scene, making sure you're dispatching an ambulance and other providers that can provide that high level patient care, because it's not just the cyanide endo kit that we're talking about. It's good airway management. It's other skills, and making sure people are comfortable. Because I think what happens and what happened in the past is things that make providers anxious make them feel like, I just want to throw the person in the ambulance and go to the hospital. So if you train people and help them understand why it's important, then you're getting better care at the scene and then better outcomes. And it's even more important for our firefighters. I think most fire academies train using some of the firefighter down principles of how to get a firefighter quickly out of protective gear, provide assessment and care, but that also increases confidence in your whole system and gets people focused on, it's us that have to save our colleagues, our brothers in the fire service. We need to be there for each other as well. And I think that helps this message resonate.
Yeah, Chief, could I ask you to jump in there for a second? So you had mentioned that as you have made them more available and socialized that the treatments are available, you're able to provide them more frequently. And then obviously, what Tommy and the doctor have mentioned is that you really need to be running that analysis in a specific way to understand where and when treatment needs to be administered. Can you talk a little bit about how you've been running that analysis, how you've been training folks to run that analysis, and kind of how that's led you to where you are today with regard to frequency of administration? Because it sounds like this is a little bit of a shift in maybe how some people are thinking about addressing the situation.
So I would say that we're fortunate in that we didn't have to pick and choose where we were going to put the antidote, right? We were able to kind of make a blanket statement and say we're going to put it everywhere we possibly can on our transport units and our supervisor vehicles. And even that, though, was sort of we analyzed in our data shop, essentially, is this even the right place? And if it is, that's great, but why isn't it there? And so that's when we had to make some changes to our response packages to make sure that we had the right resources on the initial alarm. Because I can say that personally, there were a couple things that led to the medic unit being added to the box alarms. And it wasn't us, it was a couple of fires where we made a quick rescue inside the door. And to the doctor's point, they removed the victim. The victim became a patient, but really never got, never got adequate care. I'll be honest, they got put in the ambulance and they got rushed to the hospital. And we, had we the right resources at the right time, would have been able to render much better treatment to that patient.
So speaking of treatments, we've mentioned the treatment and we've tossed around cyanokit. What is cyanokit? What is the treatment? Can we talk about that for a second?
Cyanokit really takes advantage of some basic chemistry. We all learn chemistry and we sometimes kind of forget it as we move down the road. But hydroxycobalamin is, just a form of vitamin B12. And when it combines with cyanide, it creates cyanocobalamin, really another form of the vitamin, and water. And that's something that you can just clear with your kidneys. You can urinate it out. There have been multiple different treatments for cyanide over the decades, but many of them required multiple steps or caused some, frankly, potentially unacceptable conditions like, we would give people nitrates, and that would lead to low blood pressure. It would sometimes cause methemoglobinemia, and it was really aimed at industrial cyanide exposure. Hydroxycobalamin was really the first easy to use antidote that can be deployed in a simple way, can be used by any paramedic. So you give the appropriate dose, it scavenges, if you will, the cyanide, turns it into cyanocobalamin and water. It makes every part of every fluid in your body quite red, because it's a very bright red substance. So you're peeing red, your tears look red, your spit looks red, your sweat looks red from it. But it's very safe if you're thinking about, okay, I'm just giving you a very big dose of vitamin B12 to treat your cyanide poisoning, which is lethal. It's really made a step forward in how we treat this. Before this, we really weren't effectively able to treat cyanide poisoning in the field.
I've been very intrigued by the DC program and the way you all are advancing how you use it. So my question is, have you seen, and you touched on this a little bit, but have you seen decent response from the department in terms of the ability to have this treatment and utilize it for both the community and for the department?
Anytime that we can push out a medication or treatment or advancement that shows improved results for our patients, or shows almost, I don't want to say instantaneous, but when you can give a medicine to somebody that otherwise would have had a significantly worse outcome and know that they didn't, the response is incredibly well received. Right. So that's the public side. The private side is that we have a lot of EMS resources dedicated to our structure fires now from the start, because we are trying to take care of our members. Right. And it took me a couple years to get to the point where we were able to see a member had an emergency with their SCBA, and they ended up getting 2 cyanokits. Right, they were evacuated from the building and received 2 cyanokits, and actually were discharged within like 24 hours from the hospital. They didn't have any burns or anything. It was a mostly smoke emergency. So when you have a case like that, and then that case spreads throughout the department, that we took care of our own, and we took care of our own appropriately, the reception from our members and from our department is phenomenal. I've often said there's a few things that EMS is going to do faster, as the doctor said, to take care of people, particularly take care of our own. Cyanokin is about second on my list of the things that are going to be most effective for our members in the event they have a medical or traumatic emergency when they're working.
Michaela, can I add to the chief's comment there? I think it's important. You asked a question earlier, and I cited the data from the civilian population, but I think it's also important to understand the data within the fire service. So now I'm going to say, or give you the data from the U.S. Fire Administration with regards to firefighter fireground injury. The most common cause of injury on the fireground to a firefighter is smoke inhalation, and that does account for about 33% of fireground injuries.
How'd you guys get into the smoke inhalation field in general?
I'll start. I saw 8 cyano kits on a shelf at a warehouse and didn't think it was appropriate.
I had been involved in hazardous materials preparedness and emergency preparedness for a long time before I was involved in fire-based EMS. And we spent a lot of time focusing on identifying the effects of various toxins, toxidromes, and how we should position antidotes. And what I really saw is this huge gap. So many places stored, I mean, it was almost a worst example of what Ryan's talking about. There were, regional caches of all these antidotes for things that were going to kill you in 5 minutes. And I'm like, okay, it made someone feel better to do this, but it's not actually going to help people. It's not going to help someone who's exposed. So we looked at ways initially to provide the cyanide antidote kits through some Homeland Security money, and then that kind of dried up, and then we were kind of going through processes to make sure we had these available frontline in the field, along with some other antidotes.
So smoke inhalation actually hit personal in my family in 1999. I was very early in the fire service. My dad had remarried, and his wife had a couple children, or had some children that were involved in a structure fire in 1999, and they both died of smoke inhalation. And so while I didn't know them incredibly well, because it was very early on, what I did see is how smoke inhalation affects families long after the patient has died. And it really was devastating to my family. My dad's side, it was incredibly tragic, and he was never the same. So I think we have to also, the way I look at it is, it was always interesting when this opportunity came up, it was interesting to me, but it's also, we need to reflect that it's just not a loss at that moment, that these losses from smoke inhalation have long-lasting effects to families. And it was interesting to me, especially after talking to some other firefighters that did have better resources on scene, were able to provide better care. And then the opportunity from SERB came up to where, could you help us understand the fire service? So that's how I kind of got drawn in, but it initially goes back to a loss within our family that was incredibly tragic. They were very young. And I just felt that there was some kind of calling for here.
I'm so sorry to hear about your loss, but thank you for being here today and for helping to tell this story as well. I know it's very important to help educate and to help understand a little bit more about where we are with smoke inhalation and treatment. Tommy, could I ask you to talk about the firefighter promise?
Firefighter promise is something that SERB Pharmaceuticals initiated, and it was really the result of a loss of a firefighter paramedic on the East Coast, that it was identified in their line of duty death report that there was inadequate access to hydroxycobalamin on scene, and the individual had suffered severe smoke inhalation. So one of the things that the company has done is put in what's called the firefighter promise, and that is that if any firefighter or first responder receives hydroxycobalamin that goes by the brand name Cyanokit in the field for a rescue, that the company will replace the drug for free. So any department uses it on any firefighter, first responder, pre-hospital. It's a simple form you fill out, and the company will replace it. And it's their promise to the fire service to help.
What do you think our listeners need to know that we haven't discussed yet?
The other thing I want to say is that, I'm blowing smoke at Ryan probably, but no pun intended. I think a lot of us look at the example of what they've done in DC as best practice. Now, not everywhere has all those resources, but I think everyone can learn from what they're doing, right? Everybody has some resources that go to every fire, whether it's a battalion chief. Not every place has ambulances immediately available, but you should have a goal to try and get there, right? You shouldn't be just comfortable with what you have. You should find a way to use the resources that are there. We in our situation, I don't have as many advanced life support resources, but I do have some paramedic supervisors, not as many as they have, and I do have some paramedic ambulances, and we have piloted what are called paramedic echo units, which are non-transporting advanced life support resources that can get to a scene and be ready to care for someone, and then can support any ambulance. So if I didn't have an advanced life support ambulance, I could still have paramedics there caring for the patient, and they could go with them in a basic ambulance. And I think the real goal is, however your situation is set up, many places have paramedic engines and other paramedic resources. But if you don't have the supplies that you need, the cyanic kit that we're talking about, first sign and antidote treatment, but also other things that you might need if you're only maybe limited use of video laryngoscopy, which is very handy also in fires, make sure the specialized stuff gets to the fire, because that's a place you have a predictive, you can kind of predict that you'll need it there. And again, everybody's situation is different, but you should look at it and you should try to get to that resource availability. The one thing I'd say is that we're talking a lot about cyanide exposure because it's something that gets missed. It's an opportunity to treat. But I think that we should be thinking of the whole picture of fire victims. So we should be ready to treat every part of that. Again, an early airway obstruction, significant burns. Are we really staying up to date on burn management? We really want to provide, as fire departments, comprehensive care for a fire victim. And that's what we should be training on, and what we should be thinking on, and what we should be doing in terms of our own process improvement activities, right? We should be looking at every patient we treat and learning how to do it better.
So jumping off of that, and I'd love to do a little lightning round for a second. And Dr. Dunne, we'll come back to you because I don't want to put you on the spot. But with all this information, what would you say is, if you could share one thing that people need to understand about smoke inhalation and treatment, what would it be?
For the one thing, after working in the field for about 20 years, is that smoke has changed. We have to adapt, and we have to adjust appropriately. And having the antidote available on the fire ground scene is incredibly important. And it's something that each department should strive for.
Chief?
I would say don't underestimate smoke inhalation. If I would say that there's one thing that we could always do better at in EMS, and don't underestimate our own members. I tend to think that we are, that the fire service makes the worst patients. So for when you have to treat one of your own, treat them aggressively, be aggressive, give them good care, give them the best care you're going to give them in your career.
Dr. Dunne?
What I would say is that both of those lessons are something we need to make sure we're training on and teaching every new person to get them to that comfort level of treating a fire victim. Obviously, there are still a lot of fire victims out there, but compared to other patients we take care of, like shortness of breath on a daily basis, you may not treat that many fire victims as an individual medic. So you want to be trained, you want to be ready, you want to have that mindset, both when you're treating anyone that's coming out of a fire, whether it's one of our own or whether it's a community member.
Thank you to our panelists for taking the time to share your expertise, and thanks to our listeners for joining us for this conversation. As we continue working to improve safety, prevention, and awareness, every conversation and every action helps strengthen protection for firefighters and communities alike. Thanks for listening, and we'll see you next time.